So our group, Maddie, Emily, and Nicole, I'm Emily Youngstrand, have hyperkalemia and hypokalemia. First, we are going to start with hyperkalemia. So just to start off with some basics of hyperkalemia, hyperkalemia is defined as high serum potassium levels, which are considered to be above 3.5 to 5.0 milliequivalents per liter. For the site of origin, it is going to be an ectopic pacemaker. The rate is usually normal. There are some cases where bradycardia occurs, but like I said, usually normal. And as for regularity, we were not able to find any notes about regularity specifically for hyperkalemia, but with some EKG strips we found, it did look like they all had a regular rhythm, but we can't assume that that is the case for all hyperkalemia cases. So now into the specifics of the EKG strips. As for the P wave, it will flatten out and widen at about 6.5 to 8.0 milliequivalents per liter, and once it gets beyond 8 milliequivalents per liter, it will start to disappear. The PR interval can either be normal or prolonged. It's not super affected by hyperkalemia. The QRS complex will widen, and there is an interventricular conduction delay, as lead 1 looks like a left bundle branch block, and in V1 and V6 it looks like a right bundle branch block. And as potassium levels reach 10 milliequivalents per liter, it becomes very slurred and wide, and it may merge with the T wave that follows, resulting in a sine wave sort of look. The ST segment will disappear, and the T wave becomes very narrow and tall at about 5.5 to 6.5 milliequivalents per liter.
Some causes of hyperkalemia are the pathophysiology, such as kidney failure, and diuretics that cause the body to retain potassium. Also, there are underlying comorbidities with hyperkalemia and dehydration, type 1 diabetes, Addison's disease, and some medications such as chemotherapy drugs and ACE inhibitors, which are angiotensin-converting enzyme inhibitors, as well as angiotensin receptor blockers. Some symptoms people experience with hyperkalemia are tiredness or weakness, feeling of numbness or tingling, nausea or vomiting, trouble breathing, chest pain, or palpitations or irregular heartbeats. In extreme cases, you can also see paralysis or heart failure, and if it's left untreated, the high potassium levels can cause your heart to stop. As far as signs, the only signs we really saw were the possibility of bradycardia, which you could recognize with an EKG. Some medical treatment options include calcium, beta-androgenic agents, insulin, diuretics such as loop diuretics, potassium-sparing diuretics, and thiazide diuretics. And these can help with just excreting the potassium out of your kidneys faster, as well as resin, which you can take resin by the mouth to help it bind with the potassium, allowing your body to remove the potassium during your bowel movements. And then there's device therapy such as hemodialysis, which hemodialysis uses a machine to remove waste from your body, including excess potassium when your kidneys can't filter your blood effectively.
So as was mentioned a few slides back with the QRS, P wave, all that stuff, this 12-lead EKG strip shows in lead 2 at the bottom a very peaked and narrow T wave and no P wave. And I mentioned before that we couldn't find any regularity notes on this, but this appears to be pretty regular, although this is just one strip. It's not obviously an exhaustive list of what other hyperkalemia EKG strips will look like.
Okay, moving on to the second half of our presentation, let's now take a look at hypokalemia. Okay, so if you paid attention at all to the first half of our presentation, you can probably take a pretty good guess at what hypokalemia is. The definition of hypokalemia is basically just a potassium deficiency. So normal levels of potassium in the body range between 3.5 and 5 milliequivalents per liter, and anything that drops below this is considered hypokalemia. It's a deficiency. So if we look at the EKG, the site of origin is normal. It's in the SA node. The rate is usually abnormal. It could be maybe bradycardic or tachycardic. It usually kind of depends on the underlying rhythm and the way your body usually responds to the hypokalemia. The regularity of the EKG, again, just kind of depends on the underlying rhythm. But we'll take a look at the major defects in the EKG, the major landmarks that we want to look for, in the next slide. This slide summarizes the major characteristics we want to look for when we're looking at an EKG and trying to diagnose hypokalemia. So the first thing we will notice is that the P waves are tall and symmetrically peaked. These will show up in leads 2, 3, and AVF. And this often looks like P pulmonale because of that tall peaked look. So this is sometimes called pseudo P pulmonale. So before we kind of jump to conclusions and diagnose this, we need to look at other characteristics of the EKG. So next we'll notice the QRS complex. QRS complex gets wider. So as levels drop, this kind of gets wider and wider. The EKG changes quite a bit as levels drop lower and lower. And the QRS complex is one of these major changes that we're going to see. It will get wider as the levels get lower. The ST segment is typically depressed. The T wave is another major thing that we want to look at. So the T waves will kind of flatten and turn into a U wave. So the U wave is just kind of like an extra wave that comes in after the T wave. And this will flatten as levels lower. It will kind of look like a double humped T wave if you look at it on the EKG. And if we look at the U wave continues to get bigger and the T wave continues to get flatter. So the U wave kind of takes over the T wave and gets taller as these levels get lower. QT intervals will often also be prolonged. But the major things that we're going to notice here is these tall peaked P waves and the presence and enlargement of the U waves. All right, so let's look at the causes of hypokalemia. So vomiting, gastric suction, and an excessive use of diuretics are the three most common causes of this dysrhythmia. So all of these things involve losing a significant amount of fluids from the body, which really screws with your electrolyte balance and can kind of throw off and lower your potassium levels. So one thing we really want to pay attention to with an excessive use of diuretics, as we talked about in class, a lot of patients with heart problems will be prescribed and using diuretics. And this causes an excessive amount of urination, which again, losing all those fluids screws with your electrolyte balance. That's just something to pay attention to when diagnosing hypokalemia. Low magnesium levels and high doses of penicillin are also some causes of hypokalemia. Some underlying conditions that can contribute to low potassium levels are adrenal gland issues, hyperthyroidism, diabetic ketoacidosis, and Cushing syndrome. For anyone that doesn't know, Cushing syndrome is caused by an excessive exposure to cortisol. So this is what we're going to see. We might see this in patients that have been taking a lot of steroids. So that's just another thing to kind of look out for and can help contribute to diagnosing hypokalemia. All right, so what are we going to see in patients that have hypokalemia? So the major signs and symptoms are polyuria, muscle weakness, fatigue, constipation, muscle cramping, palpitations, and in some very severe cases, you might see some paralysis, respiratory failure, breakdown of muscle tissue, and ileus, but these are only really going to be seen in super severe cases. Some of the signs, the physiological signs you might see are fibrillation, tachycardia, bradycardia, and premature heartbeats. So treating hypokalemia can involve medication treatments or device therapy, but typically how we're going to treat this is by treating the underlying condition that is causing the hypokalemia. Hypokalemia can be prevented by eating a high potassium rich diet. So eating a couple extra bananas every day can help prevent this deficiency in potassium. So here's an example of what hypokalemia might look like on an EKG. If we look at lead 2, the major thing that's popping out at us here is that really big TU wave. So in this case, the T wave is kind of slurring and merging into the U wave and causing just one large U wave. But in some cases, you'll see a separation of the T and the U wave, so it'll kind of just look like a double humped T wave. We're also seeing here a prolonged QT interval. You can see the depression of the ST segment. And again, the major characteristic here is that prolonged big U wave. All right, next we're going to go into some examples here, but before we do that, I just wanted to give a little bit of a summary slide to kind of show exactly what we're looking for. This is an image that I found online that I just thought was a really good breakdown of what we're looking for on the EKG in terms of hypokalemia. So the only thing I don't like here is it shows that the P wave's a little bit flatter, which is not what we talked about. Typically we see that pseudo P pulmonale, right? Side note, just to add in that the bigger P waves are typically seen with more severe hypokalemia. But this P wave, that's the only thing I'm a little upset about here. But other than that, you can see really well the ST depression, and you can see what I was talking about when I said the double humped kind of T wave. You see that T wave and it dips and then it turns into the U wave. So this is really what we're looking here in hypokalemia, but we'll show some examples on the next couple of slides. All right, so let's do some practice at identifying these. So the next couple slides are going to show some examples of EKG strips showing both hypo and hyperkalemia. They are not labeled, so take about 5 to 10 minutes, or really however much time you need. Go through each strip and write down which one you think it is and why. So what kind of key things you're looking for here. This is just some good practice at identifying those key characteristics of both hypo and hyperkalemia and how to identify them on an EKG. So take a couple minutes, go through these strips, and then I will post slides following where I will identify which dysrhythmia it is and then go over what we were looking for. So go ahead, take that time and go over it at the end. Okay, so number 1 was hypokalemia. The big giveaway here was that elevated TU wave. So you can kind of see in lead 2 especially how that T and U wave kind of merge together. You can also see how the ST segment depresses a little bit. So both of these are key identifiers for hypokalemia. We can see the same kind of pattern happening here in lead 3. Lead V4, V5, and V6 as well. You kind of see that ST depression and that double humped TU wave. So number 1, hypokalemia. Okay, so number 2 is hyperkalemia. So we can definitely see here there is no P wave and we have those tall peaked T waves. So those were again the 2 major landmarks we're looking for with hyperkalemia. Again, as Emily said in one of the earlier slides, the P waves can either be kind of wide and flattened, or they can be completely absent in people with, especially with people that have higher levels of potassium. So this is an example of hyperkalemia. All right, number 3 was also hyperkalemia. We can definitely see that T wave here is super peaked. It's almost as tall as the QRS wave, especially in lead 2. Again, there is no P wave here, so number 3 is hyperkalemia. Okay, the answer to number 4 is hypokalemia. This one is a little bit trickier to see. You might have gotten thrown off if you got distracted by the notched QRS wave showing like a bundle branch. But if you can look at lead 2, I think you can see it best in. You can see that TU wave kind of merged if you look really carefully. You can also definitely see the ST depression. And the P wave is definitely a little bit peaked on those ones as well. So again, what we're looking for in hypokalemia is peaked P waves and that TU wave merged along with a depressed T segment. So number 4, hypokalemia. Number 5 is hyperkalemia. So we can see in lead 2 there's not really any P wave, and the T wave is a little bit peaked. It's a little bit harder to identify here because there's definitely some bradycardia going on, which again we said could correspond to hyperkalemia. And you can see in V4 and V5 you can definitely see that peaked T wave as well. So number 5 is hyperkalemia. All right, number 6 is hypokalemia. So again, we're looking for the peaked P waves, the T and U wave emergence, and some ST segment depression may also be present. And this one, if we look at lead 2, the first thing we notice is the peaked P wave that almost looks like P pulmonale. It's taller than normal, and it definitely has that kind of peaked top. You can also really see here, this is a good example of that U wave. So we can see it definitely in lead 2, but if we look at V4 and V5, we can really see it very well, that exaggerated T wave that then turns into the U wave as well. So number 6 is hypokalemia. Number 7 is also hypokalemia. This guy didn't take a very good EKG. There's a lot of interference going on here, but it is a good example if you can see that peaked TU wave again, especially in V4 here, but also in lead 2, it's definitely present. You can also see a little bit of the peaked P wave, which is another characteristic again. So number 7, hypokalemia. All right, that concludes our presentation today. Thanks everybody for watching. Here is a list of our references in case anyone was super intrigued and inspired to go do some more research on hyper and hypokalemia. Side note for Katie here, we just wanted to mention that I did more of the reading on the slides because Maddie and Emily did more of the writing on the slides. So that's kind of how we divvied up the workload here to make it more even. Anyway, thanks again for watching, everyone. I hope everybody has a super awesome, fun weekend, and also everyone in class for our last week of class next week. Yay! Okay, thanks again, guys. Have a good weekend.